everybody. Dr. Cabral here with the Resilient Aging podcast. We have Rachel Wiley today. I've known her for at least a few years now. We've been colleagues. So she is a nationally recognized occupational therapist with a niche in dementia care, and she's the founder of the Dementia Collaborative and Dementia Consulting. And she has over a decade of experience in dementia care. She provides evidence-based training and resources for occupational therapy practitioners, care partners, and organizations across the country. She's a master trainer for the Skills to Care program, a published author, and a passionate advocate for person-centered, rights-based approaches to dementia support. Whether presenting at national conferences, collaborating with family members, or facilitating her Dementia Squad community, Rachel's work centers on practical strategies that honor autonomy, reduce distress, and spark meaningful engagement. I love that. Those are all of
Thank
my
you, Dr.
values
Cabral.
too.
I love it. This is why we're such great colleagues.
Yeah. And so when I heard about this CARE checklist, a little bit about it, I was like, wow, what a huge thing to take on. So needed. And I just want to firstly commend you for
Thank you.
even your willingness to look into this. Wow, it's so needed. And so maybe we can jump right in and I can ask, so for listeners who aren't familiar, can you tell us a little bit about the common dilemmas that residential care communities face when intimacy and Alzheimer's and related diseases and consent all intersect?
Absolutely. So I can give at least one example of kind of how this all started.
Yeah.
So I received a phone call from my colleague and friend, Megan Dooley. She's an occupational therapist in North Dakota, and she is the co-creator of the CARE checklist. So she's actually who initiated this project and got to kind of bring me into it. So I got a call from her explaining a situation that happened at a care facility there in North Dakota where there were two residents living with dementia. One of the residents he was stroking the other resident's hair. I think he leaned in to give her a kiss on the cheek. They were holding hands. And from what I understand, both parties' families were aware of their relationship. They thought it was wonderful. They were very happy that this was happening. And the challenge was that when Medicare surveyors come in and saw this happening or saw the documentation about this happening, they identified that this was not a consensual, intimate interaction because both parties had dementia, and they actually cited the facility for sexual abuse. So the facility ended up with both a fine. They were prevented from admitting new residents, I think for 6 months or something like that.
Wow.
And from my understanding, this facility was actually considered like a gold standard facility before this incident. They were actually used by CMS as like, this is an example of what beautiful care looks like. No dings or history of anything like this before. And as a result of this incident, they actually ended up discharging the male resident. And then the female resident ended up with a escalation of behavior, agitation, challenges, because she no longer had that support from somebody who was so meaningful in her life. So anyway, all this to say, this incident happened. The North Dakota Long-Term Care Association was trying to be really supportive to this facility. And so they said, we're going to see what we can do to try to hopefully prevent something like this from happening again. So they consulted with Megan Dooley and then myself, where we tried to just dig into the research to figure out, is there a tool that exists to help us navigate situations like this? And when we found out pretty quickly that most people don't want to go near this subject because it's kind of scary, we ended up kind of collecting the research that was available and developing the tool ourselves. So that's kind of where we're at.
Thank you.
Of course.
So it sounds like what happened was devastating on many levels.
Absolutely.
For the two residents, for the families, for the staff, for the facility who had this gold star.
For the community itself, who, they were struggling. I don't believe they had, an overwhelming number of care facilities. So otherwise, I believe there was a wait list to try to get into the facility. And so now there's this hold on having beds available. Yeah, you're absolutely right. It impacted people on so many different levels.
And this was based on reviewing documentation about these incidents of, contact and affection or intimacy, and that individual auditor decided that was not acceptable. And I'm curious, is that So I hear stories like this all the time, in different ways along huge spectrum. And most people don't know this is happening until they're faced with it for their family. And what a
Yeah,
tragic, traumatic crisis occurs, like
exactly.
this, for example. And just even you mentioned like the beds, like other families could not get their person in there, and like the ripple effects of that,
Yes,
say for the care partners who are already like crushed and like exhausted and sick and, doing their best, and then they have to wait even longer, and then everything spirals out of control. So just again, like
exactly.
what a huge need that this here is. And I just also want to add that a lot of these things in our world, we were talking about this before we got on the call, like there's so many things that happen like this where it's like, how is this still happening? How do these
Yeah,
things still happen? It's time to change. And this is a huge step in the change. And it's like, it comes down to, I think, to oversimplify, like whose needs are being met by that decision to
exactly.
just say, do all the disciplinary actions and all of that happen.
Exactly. Well, and that's it. I think the facility's response, they were devastated
Yeah.
because they pride themselves on providing compassionate,
Hmm.
quality,
Yeah.
safe care. And so they, I believe they said to us that their reaction was almost like, oh my gosh, now we have to prevent all contact because that's the only way to keep everybody safe. When the pendulum swings so far that other direction to try to, quote, protect our residents, that we're going to see a massive impact on quality of life if we're not allowing any residents living with cognitive impairment to have any form of human touch. So yeah, it's just, I think this is what happens when we don't have policies in place. Then we leave it up to individual interpretation, and then things like this happen.
And we saw what happened with a significant decrease in human touch for this population, older adults who are dealing with Alzheimer's and related diseases. Much quicker decline, much quicker death
Yes,
across the board. So that was an unfortunate natural experiment for this. And then there's going to be
yes,
more antipsychotics or more, like medications because more
exactly.
agitation. People need touch and, that these kinds of things. So, all right.
Yes.
Well, I'm so curious to hear like what are the components of the care checklist?
Yes. So I should say, I guess, that the CARE checklist itself is a simple assessment to assess, is someone consenting to some form of intimacy in that moment? But we realized that that checklist alone really was not the whole picture. We needed to figure out a framework of when do we even use a checklist like this. And so that's kind of where this entire procedure or framework came into play. So the CARE checklist itself, the actual assessment, is context, autonomy, relationship, and engagement. So we're really looking at, again, the context of a situation. We have to think about not just what's happening, but what's all of the context behind it. Again, like the example that I provided of that care facility in North Dakota, having the context of, yes, these two individuals had been holding hands previously. The woman's behaviors increase when they're not together. Both families are aware and approve of this situation. All of that is really important context. So we needed a framework that was going to try to capture all of these different components to establish, when is this appropriate and when is it not. So yeah, the framework itself has lots of different pieces to it. Is it okay, Dani, if I dive into some of
Please,
that?
yes.
Okay, so the first thing that we really want to consider, and again, all of this is based on not only personal experience and talking to these facilities, but also on a lot of the research that's available to us. So one thing we wanted to make sure was true across the board. So this is for all new residents. We're recommending that we have a thorough personal history intake form. So not just a blanket demographic information, but we really want to capture what are these persons' preferences and what were these persons' preferences even before their cognitive impairment with regard to intimacy, physical touch, human touch. So are they someone who was a hugger? Did they really want to hug everyone or touch everyone that was around them, or did they avoid hugs at all costs? Were they someone who co-slept in the same bed with their partner or spouse, or did they sleep in separate beds in separate bedrooms? All of these seemingly little things are really important to capture so that when we have a moment of intimacy, when someone has cognitive impairment, again, we have better context for, is this within their norm or would this be outside of their preferences? So I think that's an important place to start, is just gathering important background information. And again, we recommend that that's true of everyone, not just people who come with cognitive impairment.
And background information on everything, like the
Yes, yes,
person's like
yes,
unique interests and their
yes.
routine and like those things that would be so valuable to invest that time and energy at the beginning. And
Yes.
get yeah, so big.
Exactly. Well, that's it. I think some care facilities are pretty good about asking things like, food preferences, for
Yeah.
example. But I think a lot of times we ignore intimacy questions because we're afraid of asking those
Yeah.
types of personal questions. So we're recommending that, this is just part of the intake forms. Of course, residents can choose not to answer if they're uncomfortable, but we think that it should be incorporated into the process at least. So that's, I think, kind of the foundation. And then once we get into the kind of determining, does someone have the capacity to consent or do they not? That's when things get a little bit more nuanced. So I do want to note that this came up over and over again in the research. Capacity should be assumed. So if we don't have any other reason to believe that someone lacks capacity to consent, the assumption should be that they do have capacity. So for example, I'm not going to just like see any resident and say, oh, well, they're living in a long-term care facility. We have to assess their cognition because they might not be able to. That would be against everything in the literature. So we really want to have a reason, like, do they have some sort of diagnosis of cognitive impairment? Are we noticing behavior changes or changes in their day-to-day function that indicate that they have impaired cognition? That would trigger some of this process. But if we have no reason to believe that they have cognitive impairment or any other concerns, then we assume capacity. So if we believe that they have impaired cognition, then we do recommend that we do at least some sort of cognitive screen. We recommend the MMSE because that has some data in the literature about kind of different scoring cutoffs. When I say the MMSE, I'm talking about the mini mental status exam. So it's similar to a lot of other cognitive screens that are out there. Other ones, things like the MOCA or the SLUMS. But again, we just went with the MMSE because of the data that's available. I also want to reiterate here that cognitive assessment alone cannot and should not determine capacity. So this is just one piece of the puzzle. So using the results of a cognitive assessment, and then the really important piece would be using that information with an interdisciplinary team. And that interdisciplinary team can include a physician, it can include family, it can include nurses. Lots of different people could potentially be on this interdisciplinary team, but we really need to have multiple perspectives that are considering, again, the context, the results of the cognitive assessment, and together making that determination about, do we believe this person can consistently consent or not?
So can I jump in?
Yeah, please.
So just for those who aren't as familiar with the word capacity. So often people confuse capacity and competency. They often say competency. So I just want to mention, so competency is a legal determination. And that's if a person can basically make decisions to be responsible for themselves in general, like with everything, ultimately decided by a judge. It's a legal determination. Now, there may be medical experts involved who help determine if the person has competency, but we're talking about today capacity. Capacity, and you can tell me your, view on this, but I think of it as like the ability of a specific person to make a specific decision at a specific time. So it's like a snapshot. So it's like today, does she have capacity just to decide to do stand-up paddleboarding on a lake in Vermont, right? Even if she doesn't have great balance. So yes, she knows the risks and the benefits and now the capacity. So it's interesting. I kind of felt like a pushback inside myself when you said we assume someone has capacity.
Yeah, tell me more.
Because to me, to have capacity, you need to do a capacity evaluation. Like you don't assume yes or no either way.
Yeah.
And so I, as a psychiatrist, have done lots of capacity evaluations previously in different ways. And then more recently with, in my field, it's often like, does the person with Alzheimer's have capacity to make financial decisions at the time, right? And so and we'll get into the second, but for those of you who know someone who has Alzheimer's or similar diseases, like things can change day to day in cognitive abilities. And so the capacity evaluation comes in, it's most important when it's a higher risk decision. There's more at stake, right? And so that's why financial things or driving or in this situation like intimacy and sex and things like that could have major repercussions. So anyway, I just wanted to mention that.
Yeah, I really appreciate that, Dani. And I think in the context, and I appreciate that because it probably does need some additional clarity. When I say capacity is assumed, I think we're talking about like the greater, or at least the research that I read in this case, the greater population. Like I'm not going to intervene with my friend and be like, you know, chose to kiss someone at the end of your date. I need to assess your cognition to see if that was appropriate. Does that make sense?
Yeah, no, definitely. But I think the challenge is if you don't work with people who have Alzheimer's and related diseases, and if someone has really good social skills, really good at speaking language, they're very, they're very social, likable, outgoing. They may sound like they're perfectly doing fine to the average person who then is like, or even like a healthcare professional who's not skilled in this, who'll say they're fine. Like, let them do what they want. Clearly, like, look at them.
Yes.
Like they just said so confidently, such and such. And it's like, well, no, like you can't just base it on that.
Absolutely. Yes.
So I just wanted to say that because you have some people who are in like well into moderate stage of dementia who like
have really high social behavior.
Although I'm probably just playing devil's advocate here because I do
No. I think that that's important. Yeah. No, I 100% agree with you. And I think if someone has any sort of history of cognitive impairment, so if there was ever any reason to do a cognitive screen with them in the past, they have a diagnosis, there's any history of cognitive impairment, 100% we would move forward with assessing capacity. I think it's more for like if a new resident was admitted and there wasn't otherwise a policy in place to do a cognitive screening for everyone and they're moving into independent living to live, this couple on their own. They have no history of cognitive impairment.
And doable for a facility. It's not too much to take on. Like they have to do it for everyone. Like that's excessive. Totally.
Yeah. But no, I really appreciate that. I think that's important nuance there. And you're absolutely right that kind of like social behavior or comportment, we can't let that mask someone's, ability to consent or not consent, because I think the whole point of this is not just to like blanket allow everyone to engage in intimacy. It's to really protect people's safety.
Yeah. And individuals.
Yes, really be client-centered or person-centered in that, yes, we want to protect them. We don't want them to be taken advantage of in any capacity, and they deserve human touch. So figuring out that balance is the tricky part of this and trying to pull it all together. Right, exactly. Yeah.
So I interrupted you.
Yeah.
Do you remember where you were?
You're okay. Yeah, no, I'm so glad you did. That was an important distinction. I think I was talking a bit about the using a cognitive assessment. If we know that there's any concern of cognition, history of diagnosis of cognitive impairment, anything related to dementia or cognitive impairment, we administer the MMSE. We use the scores of the MMSE, so there are different cutoffs within our checklist. That plus interdisciplinary team input to decide, do we need to assess their consent in each moment of intimacy or do we not? And that's really where do we use the C.A.R.E checklist. So I'm leaving out some of the kind of nitty gritty of some of our framework, but essentially that's kind of what this process looks like. So it would determine if we need to use the C.A.R.E checklist for a resident in moments of intimacy. So the C.A.R.E checklist itself looks at a few different areas. So we used something called the PAIN AD or Pain and Advanced Dementia scale to help inform the creation of this assessment. So it really is looking at verbal communication, but also heavily influenced by nonverbal communication to determine if someone is experiencing discomfort. So the C.A.R.E checklist looks at facial expression, eye contact, body language, vocalizations, breathing. Did I say facial expression? Facial expression if I didn't say that already. And also, how is someone responding to comforting if comforting is necessary? So the checklist itself was meant to be used often if necessary and is supposed to be quick, simple, easy, observational tool. So again, kind of the reason for that is just as you noted before, Dr. Cabral, like someone could be consenting to intimacy or have capacity earlier in the day and then not later in the day. So we needed something that could be used multiple times a day, multiple times a week to really evaluate, is someone consenting to this interaction? Does that make sense?
Yeah, definitely. It's nuanced. And again, if you have stable staff at a facility who are getting to know the residents and the dynamics and the relationships, it might not be that hard. Although I think, and you can chime in on, I think what's tough is that when this is kind of what I was saying before, individual staff members like think they know, they're like psychic, and they're like, or they want those two to like not be together. Like
Yes.
like it's other things that have nothing to do with those two residents. Is that person. Like we all, like, I think in this field, like we need to check ourselves, like in our own issue, like
Absolutely.
because we can so easily impose these on these, they are like vulnerable individuals, and we have power over them, like to make, right? So like, but to really try to honor, like, and this is what you're doing.
Oh, I, again, 100% agree. And I think a few things that kind of reminded me of, one is we do recommend that all facilities get bias training for exactly this reason. And that bias training should include, does staff, do you as an individual have any bias towards, maybe certain groups of people, but also towards the idea of older adults engaging in different forms of intimacy. We also want to be really clear that I think when we look at some of the facilities who were kind of dinged by CMS surveyors, they were specifically looking at heterosexual partnerships versus they weren't necessarily, shouting out like, well, there were two female residents holding hands down the hallway and that wasn't considered sexual abuse. So we want to be really clear, both in the staff and in our surveyors as well, any bias that we might have towards, LGBTQIA plus communities as well. All of this is important background. And we also do recommend the use of, we created a power dynamics form template as well, because I think that you're absolutely right that staff power dynamics is an important component of this, but also resident to resident power dynamics. Does someone have maybe mild cognitive impairment and then somebody else has severe cognitive impairment, and how does that impact this relationship? Or, does someone hold maybe financial power over the other resident, things like that. So those are all considerations that we want to take into account as well.
Wow. So in terms of residential care communities using this tool, I'm sure there's like a training that needs to be done, or what's that process of like implementation?
Yeah, so we have a few facilities who have been kind of our beta testers. So it helped us kind of fine tune what the process would be for training. So initially, when we presented all of the information that I'm talking about today, I think facilities were a little overwhelmed by all of these components. But the feedback we got once they started using it is that it's actually super easy and simple, that their team feels really confident. And that made us really happy, because that was the whole point, is we wanted something with low barriers to implementation that any staff could feel pretty confident using with, not a ton of training. And then the entire kind of framework, that's just everything we recommend to support the facility with how do they choose when and how to use this checklist itself. So yeah, we have a couple different options for training. One, could just choose to purchase the assessment and framework, which is fine. They can do that and then integrate it on their own. But then we do have two options for training. One would be just a leadership training only, and then the other option is a leadership training plus training of direct care staff in how and when to use this tool.
Oh, that's wonderful. I'm thinking it would be great if you were doing some simple evaluation and metrics to see how staff and residents, and there's different things you can look at. Are you able to do any of that?
Yes, we are currently collecting some baseline data to see, change, especially change in, again, staff confidence. I think it will be hard to know, will these sites be surveyed by CMS again? So we could always find out, after they have another audit, how things go once they're using this. But I think the biggest data that we're collecting and that we're hoping to see a change in is the staff confidence in how they're handling some of these interactions. We also provide a documentation template. We're really trying to streamline this because, I'm on a bit of a tangent, but you said earlier, Dr. Cabral, this idea that I think a lot of people have this bias. And so they either want or don't want maybe this interaction to be happening. Even though this is an observational tool, we do have kind of a checklist. Each line item you're observing and you're checking off what it is that you are seeing. And then based on what you check off, it determines, do you need to intervene and stop the interaction or report the interaction, or can you allow the interaction to continue. And we have a template and how to document all of that can just be really easily worked into the EMR that the facility is already using.
Great. And I see, and this is, it's a staff training intervention, I think. At
Yeah.
the heart of
Yeah.
it. And
I think you're right.
Nice, clear tools and ways to document and track, because documentation is so important when these things happen. And I'm curious if with the inciting event in North Dakota, if they had documented it differently, if that would have helped, or if it was just an auditor who was
Exactly. And I don't think we'll know for sure, but it does sound like maybe one of the direct care staff who witnessed the situation, it was either this incident or one of the other incidents. And apparently this type of thing has also been flagged in Colorado as well. So this is not just happening in North Dakota. But from my understanding, I believe the direct care staff, English might have been a second language. So the way that she documented maybe used words that made this interaction seem a little bit more intense, than it actually was. So again, and that's not her fault. That's not, nobody did anything wrong. It's just we don't think about having templates or ways of objectively documenting these types of situations. So again, we're hoping that by having some of this clear documentation that we can hopefully prevent some of these incidents. Or again, just feeling more confident, do we intervene or do we not?
And starting these conversations is huge.
Yeah.
Just having words too and a framework is a huge starting point. And I'm curious, what do you usually when we talk about sexual behaviors in Alzheimer's and related diseases, it's often because of these inappropriate behaviors or disinhibited behaviors, things like that, which are frankly less common than the more types of basic affection I think this is trying to get at. But I'm curious if your checklist fits those more aggressive kind of situations.
I appreciate you asking that as well. So from our perspective, if we were to use the CARE checklist in an incident of maybe hypersexuality or in quote inappropriate sexual act or behavior, the CARE checklist would guide you to say, stop, intervene, this is not appropriate. And so in those circumstances, then what are our next steps is really what we're getting at. What do we do now that we know that this two parties aren't consenting to that? We need to try to divert, redirect, reduce the behavior. So that's typically when, obviously I'm very biased as an occupational therapist, but we would recommend possibly an occupational therapy consult to figure out what is the kind of underlying trigger to that quote inappropriate sexual behavior so that we can come up with a care plan for what are strategies to reduce that behavior, but also respond to it when it does happen.
Okay, thank you.
Yeah, of course.
And you just reminded me in our last Resilient Aging Unfiltered episode, we had Katie Starantino, couples and sex therapist who works with older adults, who mentioned that occupational therapists in 1986 added sex as an activity of daily living.
Yes.
To their
occupational therapy practice framework.
Yeah. So occupational therapists are definitely the go-to for this. And I always say that they should play a major role in this field.
Thank you.
So, and you clearly are with this. So
thank you so
much. Anything else that you wanted to say about, before, of course, I'm going to want to.
Oh, great question. I mean, I can always chat about all of this forever. I think we hit on a lot of the big components. Again, I hope I didn't make this feel too overwhelming. I know it is an incredibly nuanced and often gray topic. And our hope is that our framework and assessment is a way of, again, making facilities feel a little bit more confident, protecting residents, but also hopefully facilitating appropriate human touch and interaction because all humans deserve that. So hopefully.
Yeah. And I always, this and the conversation with Katie last time got me thinking about, I think we all need intimacy advanced directives. We need to write down that by age 60, this is who I am. This is what's been my routine in this area. This is what's important to me. That is so helpful to our families if we are ever in a position, and it might not be from Alzheimer's or something of these diseases. It could be, you have get in a car accident, you have a traumatic brain injury, and so it changes your ability to function. So exactly. So many things could happen, and we really could help our families and our own lives, set up for what we value. So
Absolutely. I completely agree. Yeah.
thank you
I
so
love
much.
that
So
idea.
yeah,
Thank you.
so let's say for anyone, especially residential care communities and people who work, as affiliates to those, where do they find this? How can they get this training and whatnot?
Thank you so much. Anyone can reach out to Megan Dooley or myself. I can also provide my email, but rachel@dementiaot.com is the easiest way to get a hold of me there. Our website is dementiacollaborative.com, and the C.A.R.E checklist training and framework and information about the training is listed under the products and resources page. I can also provide a direct link if that's helpful. But again, yeah, you can reach out to us directly to schedule. Megan, Julie, and myself would be more than happy to chat with you about what that might look like for your facility.
Amazing. And so we'll have all this information in the show notes. And then maybe you could just mention, the dementia, the other trainings you do and just what you have available. Because you do
Thank
very
you.
unique things that aren't readily accessible. So people should know. Yeah.
Thank you, Dr. Cabral. I appreciate that. Yeah, we try to fill in some gaps wherever we can. So the Dementia Collaborative, again, has some kind of short mini courses on specific dementia-related behaviors that may be challenging, with some common triggers and common non-pharmacologic intervention that we can try to reduce some of those behaviors. We also have a Dementia Squad, which is healthcare professionals around the country who are dedicated to supporting those living with dementia. So we meet a couple times a month and have wonderful guest speakers like Dr. Cabral. And then I also have a consulting practice as well. So I'm able to offer one-on-one consulting for families for challenging behaviors or other day-to-day challenges.
Wonderful. Well, you're busy.
Thank you.
Glad you can fit in the lake time.
Thanks,
Well,
Dr. Cabral.
once again, thank you, Rachel Wiley, for your courageous, pioneering, important work that you're doing, especially with this C.A.R.E checklist, which I think is revolutionary. And I'm excited to see what happens with it and hope that it eventually becomes something that, is a standard part of these residential care communities in this area. And then for everyone else, I'm Dr. Dani Cabral, founder of Brain Love. Come to mybrainlove.com. Lots of things going on there, starting practice. And then we have the Resilient Aging Unfiltered podcast. So trying to change the narrative about what's possible in aging, and especially with brain aging. So we'll see you next time.
Thank you so much for having me on, Dr. Cabral. It was truly an honor. I'm so grateful to spend my time with you.
Can't wait to have you back.
Thanks.
Okay.